directly to record this subject, to continue talking about the multimodal investigation regarding the corneal diagnosis, especially in the refractive field. So no financial interest up till now. I'm the first, not the very first one to have, but I'm still the first one to have the MS39 in my clinic. After doing a lot of papers and research about this device to show that how great it does. MS39 complementary components like combo, both OCT-based tomography, which is a spectral domain OCT, with Placid Dusk, which offers you a sensitive and accurate topography, plus a more accurate tomography regarding in comparison with the Shinfly camera, which is affected by the dry spots and also the very faint corneal opacities. But the OCT-based tomography is not affected at all by the dry spots or the corneal opacities. We have a lot of new tools to diagnose keratoconus, feature intelligence, the problems, you know all about it, the bad and the baddie, also the billing grading for the keratoconus, also the curve displayed and shown very in details by my dear colleague, Dr. Tarek. And finally, the epithelial mapping, which is offered by OCT, which is included in this device. So we need a lot of time to talk about all technologies and all the options in this device, but I will focus today on the epithelial mapping, and we'll show it simply how to read the epithelial mapping, how does it help you to diagnose, to include or to exclude your case, so it will change the map, in my opinion. Let's talk about the epithelial behavior, which was shown by the Danish time. The normal epithelium looks as you see here, the normal, and as I believe that the keratoconus is a posterior disease, so the forward movement of the back of the cornea won't be shown directly on the surface because of the masking effect of the epithelial thinning, which happens on the top of the cone, forming this thinning, which is surrounded by a thickening all around. So this thinning will compensate for the protrusion of the stromal, for the stromal surface. So it won't be detected by the topography at the start. So this is an example for a normal epithelial map where the epithelial thickness is homogeneous all around, especially in the central part of the cornea. Almost equal thicknesses all around the central area. Normally, epithelium is thicker in the center than in the periphery, which is the reverse of the corneal thickness as well. So look here, the abnormal maps. The most important one is this sign, is the donut sign formation, which is an alarm sign for us. The donut means thinning island surrounded by thickening around, like the island and the borders of the island. And not just thinning with homogeneous epithelium around, but the characteristic sign should be thinning surrounded by a border of thickening. So the thinning is surrounded by thickening, a sign of keratoconus, if coincides with the thinnest location in the bachymetry map, or the steepening anterior curvature map, and finally the high points of the elevation, either anterior or posterior, but most important is the posterior elevation points. This is the comforting sign. It's a good sign. Despite the spread, but it's a good sign, which is thickening of the epithelium all over the steepening parts. Thickening of epithelium thickness will be very significant and assuring sign if it's coinciding to a steep area in topography, also coinciding to the thinnest location in the bachymetry map. Also in cases of regaining errors after laser vision correction, as I will show later. So here the key to feel comfortable with your decision about your case If you have a epithelial map, you have to look carefully to the lines of the other curvatures and correlate all of them to the epithelial map for this cornea. If there is thinning, significant thinning on top of on the same point of the curvature, of the steepening of the anterior curvature, or suspicious points in the back of the cornea, and especially the posterior curvature map, which is more significant in diagnosis than the posterior elevation map. I'm relying on back curvature more than back elevation, and also the anterior curvature to diagnose or to suspect the keratoconus in these patients, believing in all the time that the keratoconus is a posterior disease. So we'll ask the question again, does it change the map? Normally in your refractive day, you may go for transpurity. So it's very crucial to measure the epithelial thickness. So away from the keratoconus diagnosis, the epithelial mapping will help you to define the epithelial thickness you have to put on your machine to get an accurate ablation. Because we were putting it randomly as 50 micrometer, which is not the same in all patients. So we got overcorrection or undercorrection if going for transpurate without measuring the epithelial thickness. So it will help you to define the epithelial thickness should be removed by PTK technique on your laser machine. Then the accurate diagnosis, which will make you confident in your decision, and it will offer you an honest guide for your patients. Let's start with this example. We were talking about pentacam and the MS3 line. In this patient, I will show very quickly what the difference between both machines. But what about this patient and this pentacam? Dr. Mazen, please. What about this patient, in your opinion?
The asymmetry is about 1.3.
Yeah.
Posterior
it's
anterior.
used as well the scale of 0.25. That's why showing noisy. And the thickness is fine.
Yes.
Everything's fine.
Is it keratoconus?
No.
Is it keratoconus suspect?
No.
No, yeah.
For me, no.
Now it's the pen and presume. What about it?
The slope is fine, but the average is borderline. Okay.
Yes. But until now, you are comfortable with this case to go for refractive surgery or not?
Yes.
Yeah. Okay.
But I don't go for LASIK. I go for PRK because the average is borderline.
But when we see the epithelial mapping for this patient, you will find this surprise. There is epithelial thinning with no obvious signs of appendicitis. So this is an example how this machine or epithelial mapping itself can help to Thank you, sir.
Is there any dry eye?
No.
Contact lenses?
Repeated many times with no contact lens. Very good.
Very good.
Let's continue also the roadmap.
The previous scan with a different tomographer. So it depended on, for example, the MS did it show normal in the other tomographer if you did?
No, I did this patient on the pentacam and on the MS3 line.
Okay, so
Yeah.
the MS39, regardless of the epithelial map, which was very indicated, the keratoconus indexes of the MS39, what did they say?
The classification.
Yeah.
Yeah. This patient on the classification by the MS3 line is absolute keratoconus.
Shows
So there is discrepancies between that. Okay, this is very interesting.
Yes.
So there's a keratoconic patient with no option for refractive surgery, just for cross-linking answer.
Okay.
I would be thankful to see the keratoconus report from the MS39 to know why they classified it as keratoconus. Because there are some indices to see. Accordingly, I can tell you that this machine has classified correctly, or there was maybe artifacts. Maybe.
Yeah. Okay. For this patient or
Yeah,
generally
for this one.
For this one, okay. We can find it on my laptop later.
Thank you.
Yeah, okay. So the roadmap for all of us regarding epithelial mapping, to stop, to wait, or to go. Simply by this, if you have this topography with this inferior steepening, so you will define, you will study here the epithelial mapping to know this is as significant in steepening or just surface change or hyperplasia of this epithelium. So if it's blue, which means thinning, you have to stop. If it's just green but with somewhat darker color, which is with no significant differences between the epithelium in this point or in the surrounding points, you have to wait to follow up. Don't go please, but if you have thickening, which is red sign, you can go comfortably with no problem at all. Let's go directly for the clinical cases from our center to know how we dealt with. Case one, do you feel safe to do laser vision correction for an this patient with the tarek? This is corneal thickness, it's a thin cornea. The thinnest is around 460 microns.
With a little bit of superior steepness and discrepancy. Does it have any sort of opacity in the superior area?
No, just
But
balance.
there's some hypertrophy of the epithelium. Some, it's not.
Yeah, this patient has just balance, extensive balance in the superior cornea. But do you believe in the superior keratoconus or not?
Very rare. I don't diagnose it except I have clear evidence that this is a superior keratoconus, but it does exist, but it's not that common. It's very rare.
Yes. Okay. What about the back? The curvature map. The 10-inch positive curvature.
It's good. The elevation maps are not bad here.
Okay. Also the posterior elevation lines looks normal.
Yeah.
And finally, the epithelial thickness.
It's not bad. Yeah.
Look at the epithelial thickness.
There is no thinning in the center.
Yeah.
It's a very thin cornea. This is the thing.
Yeah. The central part of the cornea, epithelial thickness is 54 and 55, and surrounding is around 57, 56, which is good.
Yeah.
Which is there's no problem regarding the epithelial map.
It could be a normal thick cornea. It could be, but it's not keratoconic cornea.
Okay, but look at the superior point here. The superior steepening with the superior.
But you mentioned there is a superior paras.
Yeah.
This could be an
So
effect
there-
of the paras.
So I mean, there is thickening here at the steep point of the superior cornea. So it's not thinning.
Yeah.
Yes, sir.
Let me comment on this, please. First of all, this is not the effect of the superior paras, because if it was because of the superior paras, we should have seen that also on the anterior elevation. We see that the anterior elevation is very symmetric. Now, this is because of the effect of the upper lid. And the tear film, which is, or the tear meniscus correlated with the tear film. That's why this is an artifact, especially it is the tangential anterior curvature that shows the K-max in this position, so this is an artifact.
Yeah, perfect. Thank you so much. This is the main cause for this superior steepening. So I asked the operator to help patient to open
The lid.
The lid properly, and so this map
Disappear.
totally changed. Okay, so the field map helped you in this patient or not?
Yes.
Yes, of course.
This is another case. How do you see it? This patient with inferior steepening. The superior inferior point difference is around 1.2. No, 2.2. So it's highly significant, especially in the central part of the cornea, and could be highly suspicious for this patient. Please, can I have another 10 minutes? The last عشان نعوض مهندس عشان نعوض مهندس.
عاوزة منك.
So, if you have this topography, you have to suspect. Yeah. حضرتك ايه يعني؟
يبدأ بالأول.
You have to suspect this patient with this, especially it's central. It's not in the center of 5 or center of 8 millimeter. But look here at the anterior elevation, it's good. The posterior elevation is good. The back curvature here is steep inferiorly, right? What about epithelial mapping? If you don't have all these, you can look here. You will find this 61 above and 55 below. So it's going to be thinner than the superior point. So the back curvature, the posterior tangential curvature is steep. Anterior curvature is steep. Thin epithelium in the same point. Even if I have normal posterior elevation, I don't rely on the posterior elevation all the time if I have the posterior curvature map and the epithelial thickness. So this patient for me is keratoconic, and I will go for treatment of the keratoconus.
I agree with you. And by the way, the posterior elevation is not normal, by the way. It is, by the way, if it is, or it was by the pentagram, this is tongue-like extension, which doesn't make any sense because if it is in the best fit sphere, because we look at the thinnest location. And I have many cases of tongue-like extension which are normal cases. But in the CSO, the system is different because it depends on the best fit, something aspheric, low glass. So
Like the
this tongue like extension is an indicator of an asymmetry. Tongue-like extension is an indicator of asymmetry on the posterior surface. So yes, I can consider it as
I have a comment on this. Because this is a personal finding, but take it into consideration. There is a difference between mechanical ectasia and the keratoconus. Okay? And I have seen cases like this, especially with eye rubbing, because the tongue-like extension usually from the temporal side, where the patient rub his eye. And the configuration of skew deviation is some sort of skewing also.
Yeah.
And the configuration is not classic for keratoconus or the genetically induced keratoconus. So it could be a rubbing induced ectasia, which we can call it keratoconus, of course, but still there is a distinction between both entities, especially because if we stop rubbing the eye, we might improve without.
But the rubbing usually affects the anterior surface more than the posterior surface. I think
Both,
I think
but this tongue, I have seen it a lot with the history of eye rubbing, and it looks like it's from the temporal side, and it is with the movement of the rubbing itself.
But just to point that the epithelial mapping, the minute finished in the just discussion. So the epithelial mapping, it will be thicker in the case of rubbing, not thin. Like the contact lens formage.
why? Explain.
Because there is mechanical
Hypertrophy.
hypertrophy.
Well, you can say that if there is complete erosion in the cornea because of the rubbing itself, this will be misinterpreted by the machines as hotspot and epithelial hypertrophy. But if the cornea is totally clear without complete erosion, still the same, it should be hypertrophy.
No.
Because of rubbing.
No.
Rubbing.
Thank you. I will finish in just a minute with the discussion.
We give you 5
Thank you so much. You are generous to talk.
minutes. Give me back the 4 minutes.
Case 3, epithelium does a great job in such case because when I saw this case, I found that there is deviation, significant deviation with thinning. The epithelial thickness is much like thin. The back is also steep. Also, the anterior surface is steep. So I feel suspicious for this patient and excluded this patient from refractive surgery. More and more, we have a lot of cases, but the time is too tight. So if you have this case finally to do laser vision correction or not, I will answer. This is the right eye, and this is the left eye with inferior steeping, very significant inferior steeping with the topography. But when I went for this this patient, I found the other eye for this patient. I found this map with highly significant or highly steeping inferior surface of the cornea with very normal curvature. So
The epithelium is thickening.
the epithelium is thickening.
Thickening, yes.
So I will be comfortable for this patient despite this highly significant or high steepening of the anterior surface. Let's go for the next, the same. Finally, what about post-LASIK? How does the 39 help you in post-LASIK? If you have patients with regression or a residual error after LASIK, you will be suspicious about the ectasia or not, and also the cause of the.
So the topic is the clinical applications of. Does it work? Yes, but I think
No.
you don't think, but maybe there is no need. Maybe there is no need for. You can hear. Just for the bottom of the room, maybe it's better. So, which are the clinical applications? If you you just mentioned that you did a lot of PhD theses. So, if you take a look at the literature, you will find hundreds of applications. So, but I want to give you some take-off messages because there are very nice applications, but they are not of big clinical utility. But there are some applications in which the confocal can make the difference in the diagnosis and in the management of cases. And these are not many, just a few, but in those cases, maybe you should be aware of when to use or when to ask for this kind of examination in your patients. You have two main systems nowadays. One is the laser scanning, and the other one is the white light IVCM. This is an example of how you can, in a normal cornea, so very easy cornea, define the microscopic anatomy of each layer, so superficial epithelium through basal epithelium. This is the anterior, this is the Bowman's layer with a perforating nerve fiber. This is about between the two, the subbasal nerve plexus. This is the anterior stroma with some activated keratocyte. This is the mid-rear stroma with a nerve fiber bundle that is bifurcated. This is the dark transparent layers of the Deschler-Duas layer, and this is the healthy endothelium. And this is another section with all the layers mentioned in the central cornea. When it is relevant in the clinical practice, if you want to measure somehow the ocular surface and corneal inflammation, it is very useful in certain kinds of corneal infections. It is useful for imaging the corneal nerves if you want to understand what is going on, for example, in neurotrophic keratopathy. It is useful in ocular surface ablation and all other kind of similar disease for the differential diagnosis, and in limbal stem cell deficiency. What is nice is that the laser system can scan through non-transparent cornea. So, to a certain extent of loss of transparency, you can have still the visualization of the endothelium. So if you want to know if in this patient, for example, you want to perform a DALC or a keratoplasty, of course you want to know if the endothelium is damaged, and you cannot do with a spectral microscope, you can do with a confocal. You see that there is the stroma involved till the very rear part, but the endothelium is fantastic in this case. Also, you can assess some kind of active inflammation. So you would not do any kind of surgery if you still see that there is invasion from the inflammatory cells in the stroma, edema with activated keratocytes, or a lot of dendritic cells in the subbasal layer. And if you see these kind of cells, so these dendritic cells, which are antigen-presenting cells, they can be resident, but to a certain level of density. If you find a lot of these cells. This means that the ocular surface or the cornea itself is immune activated. So there is something going on in terms of inflammation or immune inflammation or autoinflammation, like herpes simplex keratitis, adenovirus, allergy, graft rejection, whatsoever. So you have to pay attention. You have to maybe use steroids or cyclosporin to treat the disease before doing surgery. It is also useful in chemical burns because you cannot understand when conjunctivalization is occurring better than just the slit lamp. You can define the level of inflammation and the better sided neovascularization. Majority of the cases are asked for diagnosis of infectious keratitis. So keep in mind that bacteria cannot be discriminated because bacterial elements are smaller than the resolution of the microscope. So you will never image bacteria. So if you have a suspect of bacterial keratitis, there is no need for the indication of IPCM. But it's very useful for acanthamoeba and fungal keratitis with a high level of sensitivity and specificity. However, you cannot make diagnosis of which fungal type is. Just you can see that there are fungal items. But this might be very useful in starting a prompt treatment. Regarding acanthamoeba, remember that if you do the scan, for example, in this typical case where the immune ring is, so if you're scanning here, the immune ring is an autoimmune inflammation, interstitial inflammation of the stroma. So you will see only inflammatory cells, leukocytes and macrophages, which are not acanthamoeba cysts. So you have to look for this acanthamoeba double-walled cyst or with the signature ring sign. And maybe they are outside this ring, so you have to be very skilled in scanning the entire cornea. I show you some examples, so they were not here, but they were here. Another case in which the cornea is very opaque because of the dense infiltration, this kind of acanthamoeba keratitis, and you can look for this. This is the sign that you have to look for. So a double-walled cyst, or a signature ring sign if you get the scan that is oblique. Regarding fungal keratitis, so it is again very sensitive and very specific. It is comparable to the smears. So and I suggest to use this if you have it in all suspects of fungal keratitis. It also can be helpful in monitoring and guiding your treatment. Because if you see that there is a decrease in the density of hyphae, you're, of course, with the clinical judgment of improvement, but it means that your therapy is working, you can define the depth of the infection, and it can help you for the surgical incision. Regarding the follow-up time for the acanthamoeba, you see this was the case at presentation, a lot of acanthamoeba cysts and inflammatory cells, and then you can see what happens with your therapy. Again, you have a fungal keratitis, and you see that there are many fungal filaments, and you see that it is improving with your voriconazole and natamycin therapy. Of course, you can have your clinical signs to judge there is improvement, but also you are corroborated by the fact that the hyphae are reducing. This is a good sign. Sometimes you think you picked up the infection and you're treating this, but they are mixed infection. Like in this case, that was not responding only to the therapy for the acanthamoeba, and you see that there is a double infection with acanthamoeba and this kind of rods and needle structure, which are typical of some subtypes of Fusarium keratitis. Or in this other case, where you see that there are many cysts of acanthamoeba, you can see it here, but then you go at deep scan in the stroma in this part, and you see a lot of fungal elements. So it was a mixed infection. You have to be very careful, because if you think you treat one, but you're forgetting the other, you may be in trouble. You are always in trouble anyway when you have this kind of double infection, because sometimes it is very hard to deal with. But at least you have this diagnosis. And if you do this scraping to do your culture tests, of course it is mandatory again, and it has to be done, but sometimes you need a lot of time. Fungal usually takes 7 to 8 days to grow, and sometimes you don't let them grow because maybe you didn't pick up the right portion, or your culture is not as you expected. but you can start the treatment much earlier, with not waiting for the let's say results of the microbiological test. The other application is corneal nerves. You see some basal nerve plexus and some stromal fiber. These nerves are very important because they also interact with the function of the keratocytes, and they maintain the structural integrity of the cornea and its transparency. So you know that neurotrophic keratitis, we will have a talk about this tomorrow, is one very challenging clinical condition. Now we can also quantify the corneal nerves. There are many software that can be applied to the confocal system. If we want to use some software that are very cheap and available for free on the web, you can use the ImageJ that is also dedicated to nerves, and you can track the nerves with this. And remember that regarding the nerves, the nerve study, it is very useful in many kind of surgery. For example, we discussed a lot during this morning about refractive surgery. And you know that every time that we do refractive surgery, we do some kind of denervation, either LASIK, SMILE, or PRK. Some of these patients experience dry eye, some of them develop allodynia, they are more risk of developing a neuropathic corneal pain. So confocal might be useful in studying this. You see the central pre-op, this is the resection of the nerve in a LASIK, and this is the slow recovery of the fiber after weeks and months. Also in dry eye disease, you can study nerves because you have always some kind of nerve alteration in dry eye disease, and this can explain why some patient with a very severe dry eye, they have poor symptoms, or some patient with a very mild dry eye, they say, you have nothing, why you are complaining of, and they have a lot of symptoms. So this can explain the discrepancies between the damage that you can see with your fluorescein stain on the ocular surface and the symptoms that the patients are complaining, because the symptoms are mostly mediated by the neural component of the ocular surface. Regarding the ocular surface squamous neoplasia, we did a lot of studies in the past together with Professor Dua, and what is nice is that you don't need to do a biopsy to get the diagnosis because it's as specific as the impression cytology. If you compare with the excisional biopsy, then it's different, but you usually never do excisional biopsy unless you do optical delamination on the corneal surface. And by confocal, you have some elements and suggestive elements like the presence of prominent nucleoli and the difference in the morphology and the reflectivity of the two kind of epithelium. This is the normal one, this is the neoplastic one. And this is our reconstruction of this ocular surface neoplasia. And what is nice is that you can, again, follow up the patient after your treatment. For example, this was a patient with an ocular surface squamous neoplasia treated with interferon eye drops, and this was the follow-up with confocal that showed the restoration of the epithelium to a normal level. Last but not least is the study of the limbus. So if you want to understand what is happening in limbus stem cell deficiency, you should look at cells. You can do this by impression cytology, but it's quite invasive, and you need a lab because you pick up the cells from the surface and you get the analysis with immunofluorescence staining, for example, but you cannot pick up the cells that are in the niche where the stem cells are because they are very deep, and you cannot do repeated sampling of the ocular surface because it then is too invasive. With confocal, you can study the surface, which is exactly the same, but you can also go deep where the palisades of Vox are and where the limbal crypts, where the stem cells are harvested, can be imaged. And this is an example. And this is normal cases. But what is nice is that you can also analyze the ocular surface of patients with suspect of disease of limbus cell deficiency, total or partial, and you can discriminate whether they have a real conjunctivalization or not. Because sometimes clinical judgment is based on vascularization. But vascularization of the cornea, superficial vascularization, doesn't mean that it's conjunctival. It just means that there are vessels. And sometimes you have surprises before you do your limbal reconstruction, limbal transplantation, or let's say slat or whatsoever, because you have to be sure. And if you don't do proper impression cytology with immunofluorescence and or confocal, you might be in error. For example, here you have no vessels, but it's total conjunctivalization. You see this conjunctival type because you have all goblet cells with no corneal type, and it's confirmed by impression cytology. But the cornea is just opaque without vessel. This was a case of aniridia. We know that in aniridia we can develop, of course, but it was not a typical one. In this case, you think it's total because it's all white with almost total vascularization, but you still see that in confocal there are islands of corneal cells. So this means that maybe you can just do a panectomy, use amniotic membrane, and living surviving cells can do the job without doing living-related or auto transplant. And in this case, for example, with a lot of vessels, you see that it looked like a limbal cell deficiency, but it was the last, no problem. But it was actually a total normal cornea with just superficial vascularization after an herpetic corneal disease. So just to mention that also for the limbal stem cell deficiency diagnosis, confocal is useful. So hope to be helpful with this tip and trick. Thank you.
Thank you to Tamer for this comprehensive presentation. I'll try to change the mindset a little bit and move to something different, which is the biomechanics. More than 20 years ago, I started giving lectures about wavefronts, trying to describe tourniquet analysis, a lot of physics and VSTF, MTF. And I think I was very successful in treating insomnia. And now, because people thought it's rocket science, and now I'm talking about another branch of rocket science, which is biomechanics. I hope I will try to simplify it, because one day I saw my son wearing this nice T-shirt with Albert Einstein quotation saying, if you can't explain it simply, you don't understand it well. So I will try to be very basic and very simple in order to try to reach you in this. What are the corneal biomechanical properties? You know, elasticity, stiffness, viscosity. Simply, elasticity, it's the ability of a substance to deform under stress and then return to its original shape when the stress is gone. For example, the rubber band, elastic, we stretch it, this is the strip, and then we remove the force, so it returns to its original form. The other thing is the stiffness resistant to deformation in response to applied force. For example, an iron bar like this one.
Pointer.
This iron beam, you apply force, so if it bends easily with less force, so it's not that stiff. The viscosity, which is resistance of the material to flow, or the resistance to permanently deform, like the honey and the water. This is the most common examples to describe viscosity. And we know that in cornea, we have this quotation by Sayyidina Ali, do not be too hard, lest you be broken. Do not be too soft, lest you be squeezed. This is our cornea. Not that hard, not that soft. So we'll talk about the Corvus ST, which is the corneal visualization shine fluke technology. Actually, this machine measures something called DCR. If you are into plastic surgery, don't expect it's your DCR. Actually. It's something else. It's dynamic corneal response parameters. So the dynamic corneal response parameter, simply it's an air puff. The air puff is our force here, and there is a camera, rotating camera. It's actually a shine fluke camera, horizontally placed. It's the same like the shine fluke camera with the pentacam, and the cornea undergo deformation when the force is applied to the cornea. This is what we have in Corvus, air buff, force, so the cornea moves airwards. So this is a normal cornea. You can see this is the behavior of a normal cornea. But we have some stages. The initial stage is the applanation. The cornea is becoming flat here. And then move inwards to reach the highest concavity or the maximum inward deflection. and then the force is gone, and the cornea returns back to its initial state through an applanation tool. Those are the most important stage. Let's have a look on a weak cornea or a keratoconic cornea. This is an extreme case. I call it a dancing cornea. You can see how the cornea move inwards more and assuming a higher concavity more than the normal cornea, and the vibrations, oscillations, the timing, everything is different. It means this cornea is not stiff or very weak. This is actually a comparison between the normal cornea here, and this is a very advanced keratoconus showing weakness and oscillation. Okay, the machine measures a lot of parameters, so I will skip this to have the most important parameters, and I will go through it quickly because of the timing. First, the DA ratio. DA ratio is just a ratio between the deformation occurred at the apex and 2 millimeters to the nasal and temporal from this area. So it's initially a ratio. So this is the movement in the apex, and this is the movement 2 millimeter to nasal and temporal from the apex. The ratio between them is the DA ratio. The radius of curvature based on the inverse radius of the radius of curvature. In the SPA1, this is one of the most important parameters because it compensates for the intraocular pressure. We always think about the intraocular pressure. If the intraocular pressure is very high, the cornea will not move inwards because the intraocular pressure, not because the stiffness of the cornea. So we have to adjust for the intraocular pressure. So in stiffness parameter A1, this is the work of Cynthia Roberts, by the way. She compensates for the intraocular pressure or the biomechanical intraocular pressure. This is why it's in the applanation 1, where the intraocular pressure is measured. We have something called the stress strain index and strain curve. If I'm going to express it or try to explain it right now, I'm going to be a theoretical physicist, so I will skip it now. But the curve, so you can compare it to the main index. If it's moved to the left, so the cornea is harder or stiffer. If it's moving to the right, the cornea is softer. And you can use this curve specifically for follow-up, especially after cross-linking, after stuff like this. And you can have this indication here. So the cornea is stiffer afterwards, or the cornea showing no signs of progression here. Okay, but still we are going to do refractive surgery, and we need something quick to look at. So the oculus starting to have some indices. One of them is the Corvus biomechanical index. It combines all those indices or those parameters, and now we have this bar here, which is the CBI. If it's green, so the cornea has a good biomechanics. Yellow, suspicious. Red, it's poor. So if you want to have a look on the biomechanics of the cornea in a single index, so you have to look at the CBI. This is a cornea of a keratoconic patient. You can see that the CBI is sky high here. It's -1. It's 1, which means it's a very weak cornea here. This is the cutoff value. It's essentially 0.5, the cutoff value of the corpus. But should we move to biomechanics and forget about the topography or the shape of the cornea? No, we should go over, not beyond, actually. We should go beyond, not over, the topography. This is the words of Renato Ambrosio, and he will give us a very nice lecture tomorrow about the multimodal corneal imaging. The tomography biomechanical index is the TBI. It combines the data from the pentacam, the Scheinpflug images, and the Corvus biomechanics. So it has an artificial intelligence system called Random Forest. It gives you this famous display of the Corvus. So here you can see the stiffness parameters, the integrated radius, the DA ratio, the RTH, and here is the CBI with its value, and here is the bad D from the pentacam. This part is taken from pentacam, and this is the TBI, which combine both of them. Actually, it's not just a combination of both of them. They speak different language, but still you can have a clue about the shape and the biomechanics in the form of the TBI down there. And still it's green, red, orange, so you can interpret it with the colors. This is the case of a keratoconus. You can see the CBI is high, the D value is in yellow, and the TBI is the maximum. So this is a weak cornea. Okay, keratoconus doesn't mean ectasia susceptibility. You should understand this. For example, if you have a case like this, you don't need corvus, you don't need pentacam, you can diagnose it from the slit lamp. Actually, this is an advanced keratoconus, so you don't have to do all this stuff to diagnose keratoconus. But ectasia susceptibility is the issue because I want to prevent cases from going into ectasia after refractive surgery. Let's have some examples. So this is the theoretical part, it's gone, don't worry, you are over with it. And then we'll start with the clinical part. Dr. Mazen, we need your help here because I'll give you some tough questions as you did for us, okay? This is a case of inferior steepening, as you can see. Do you see anything abnormal in this case, Dr. Mazen?
Yeah, the inferior steepening only, the difference, inferior superior, that's it.
Okay, what about the elevation maps?
They look normal. The sphere 8 millimeter, normal.
Okay, okay. So, we all know that the pentagram is essentially measuring an elevation, and then the elevation is converted to curvature maps. So the main thing that we measure with the pentagram is the elevation. So, for example, Michael Bellin is always telling us that he doesn't look at the curvature map. He just look at the elevation maps. But we look at all maps, of course. But we can see that the elevation maps are normal, as Dr. Mazen mentioned. We see this suspicious area here. Do you see anything abnormal in the tachymetry map?
No.
Okay. The only thing we should mention here is that this scale is a little bit noisy. It's 0.25, it's a quarter of a diopter, and it's intentionally noisy so to clarify this area of inferior steepening. This case went to a lot of refractive surgeons, asking them to do LASIK. And would you do LASIK for her or PRK, Dr. Mazen?
I have to see other profiles, for
Okay.
example,
This is the documetric indices,
the BAD.
and here's the BAD.
Yes.
BAD is very promising. Isn't it?
Fish
It's
eye
perfect.
Yes. Now, they have epithelial mapping for it?
Yes.
Open filling?
Yes. Well, I'll keep it to the last, okay?
Okay.
No, she is not. Sorry.
And she is 20 years when the capture was taken.
Yeah, exactly. And she's a female. She.
Okay. How about refractive error? Or
She's,
just,
she's -2, as far as I remember.
all right.
Does the astigmatism partially fit between the subjective and the topographic one?
No, not really. As you can see, this is the importance of multimodal images or having an extra piece of information, which is the biomechanics here. We did a corvus for this patient, and as you can see that the CBI is perfect, and you can see also that we know that the BAD is good, and we now has the CBI is good, and now the TBI also gives us a very good results, which means this inferior steepening is not biomechanical or focal biomechanical error, because we know keratoconus is starting anterior or posterior or whatever, but at the end of the day, it's a focal biomechanical failure or weakness. Dr. Mazen asked for the epithelial mapping, and this was the clue that solves the solution, that solves the problem. There is some epithelial hypertrophy at the area of inferior steepening, which means this is the cause of the artifact that occurs in the pentagram that showed us this little bit of elevation.
Contact lens?
She's not, Hosam asked it already. Yeah.
Okay.
What about another inferior steep area? What do you think, Dr. Mazen?
Yeah.
Pretty similar case, isn't it?
Yes, exactly.
Perfect. You can see inferior steepening, you can see anterior and posterior elevation. And if you look at the topometric indices, it's good. And I don't know, but for me, I don't look at the TKC by all means. This is obsolete for me. I don't look at at all.
Yes.
And have a look at the D value, here, 0.9. Okay, let us jump into the corpus. Oh,
suspect.
abnormal CBI, although the D value is normal, you can see that the TBI is not good. So this cornea, although it's very similar to the previous cornea, it has some sort of biomechanical weakness. The thing is, should we believe Corvus in this case? Yes, I'm sure, because this is the other eye of the same patient. This is why I'm sure that the Corvus is right in this case. Yeah, exactly. So you can depend on Corvus when you think about cases like this. And this is, of course, the biomechanics of the other eye is extremely. We use Corvus for follow-up now. This is the ABCD we used to know from Belen in the Pentacam, and now we have the E. So we have ABCD E. E stands for the biomechanics, so we can follow up the patients after doing procedure. For example, this patient underwent intracorneal rinse, as you can see here, and you can see that we can follow up the patient after the procedure or during, for example, the case Dr. Mazen presented, we can follow her up with the Pentacam and then follow her up also with Corvus. I will present tomorrow cases, a lot of cases, the multimodal corneal imaging, but thank you for today, and I hope you enjoy.
Of the cornea. In the 5 meter ring, we have upper and lower points. The difference will not exceed 30 microns. As you see here, in case of class 1, the difference about 54 microns, which is very much. Difference between sinus location of the examined eye, fellow eye, more than 30 microns, also suspicious. Right. For diagnostic keratoconus, what are the other clinical application of this Pentacam? Of course, intracorneal cross ring. Intracorneal thickness should be at least 400 microns at the tunnel location. The corneal collagen cross-linking, the corneal thickness should be at least 450 microns. This is to say 400 microns after scrapping the 50 microns epithelium. To avoid ultraviolet injury of ocular tissues, namely the endothelium. Ultraviolet rays working on thin cornea, it may cause damage to endothelium and may cause corneal decomposition. In cornea thinner than 450 microns, now there's many advanced, many modified protocols that can use the lower amount of ultraviolet energy, which makes safety for the crosslink. Elevation maps, we have this case in which there is a reference plane presenting the average for population according to age. The patient elevation is compared with this reference surface. Any point above the surface takes plus value. Any point below the surface takes minus value. Of course, plus values are carry the risk of keratoconus or ectasia, and minus values are relatively safe. And the inferior, the normal chip is hourglass, and we should also consider much of the abnormal chips. Elevation maps for routine use we can use the best fit sphere. It has some values, but of course the most accurate is the best fit ellipsoid for keratoconus. Best fit sphere can give the normal shape. Its normal is regular astigmatic symmetric hourglass. As we see, just to remind you that in the topography we say a symmetric bow tie. In the elevation say symmetric hourglass. Elevation suspicious values for elevation and finish location according to the best fit sphere. In the anterior float plus more than plus 8, in posterior more than plus 18. For hypertropia, the values are a little bit higher, in the anterior plus 7 and posterior more than 28, because of course the risk of ectasia after hypertropia is much less than in myopia. The cone location, we can determine part from this sphere according to central cone within 3 mm zone, paracentral cone between 3 and 5 meter zone, and peripheral zone between more than outside 5 meter zone, kissing bird sign, which is usually seen in pellucid marginal degeneration and pellucid like keratoconus. For best fit ellipsoid is gives more accurate determination of the cases of keratoconus. These values are different. Here we don't use the thinnest location and best fit sphere. We use the highest plus value within central millimeter ring. In the anterior float more than plus 12 is suspicious, and the posterior float more than plus 15 is suspicious. Also, the background difference endpoint above more than minus 5 microns is also suspicious. This is the progression of corneal thickness from thinnest location throughout the concentric rings. The center, each 2 meter ring, we give it an average number, and plot the value. The zero level, the 0 point, not the center of the cornea. The 0 is the thinnest location. So in keratoconus we have all these rings shifted down, not particularly, not necessarily in the center of the pentagon. The first curve, the red line is the line of the actual line of the patient. The central dotted line is the average. The upper and lower is 95th percentile. Normal curve should follow the curves, these lines regularly until at least for the 6 mm ring. And after that it can bend, no problem. But if the curve starts bending for 6 mm, this we can call quick slope, which is seen in form frost keratoconus and other ectasia. The other curve is similar to the upper curve, but the difference is that it doesn't measure the average thickness, it measures the average percent of increase. Usually the change is more sharper than the upper curve. Here we look at the keratoconus level topography, it measures 2 to 3. As we say before, the pentacam doesn't measure curvature data. And the level keratoconus screening, it depends here on curvature data and clinical data. But this is not very accurate, but can give us some consideration of the case. This is another form of a curve which is not normal, but it's CS curve. The curve goes down and then goes up again. Also seen form frost keratoconus, other ectasias. In these irregularities, these are also this index of surface variance, index of vertical symmetry, keratoconus index, central keratoconus index, index of height data asymmetry, index of height centration, minimal surgical curvature, aberration. It's not essential to follow these numbers and consider, but that's important. It does consider if the index highlighted by white, this is okay, but it's okay. If yellow, suspicious. If red, it's considered abnormal. It's commonly seen that you have 4 or more of these in this abnormal, which goes to keratoconus ectasia. At this case, all 8 figures are abnormal. Q value is an average value describes the slope of the anterior corneal surface. Normal value comes from 0 to -1. Abnormal value after more than -1. Plus values goes with A after myopic ablation, a central ablation. But here high slope is -1.12 in the case of the with front aberrations, the most important of these of the Z5 plus 1 is higher order coma because it's characteristic of keratoconus, and also the spherical aberration Z6 because if you have high spherical aberration, we cannot do high spherical correction. Coma aberration, the most common with front aberration associated with keratoconus. Random ectasia scoring system, it's not used commonly nowadays, but it can use as a general guide. It takes into account the topography pattern, the residual stromal thickness, age, corneal thickness, mean manifest refraction, spherical equivalence. Any high value takes for a high number like 4, low value takes 0. We take all of these factors and having a common summation to calculate the risk of scoring. Topography pattern, if it's 4 frost keratoconus, gives 4. If it's normal, gives 0. Residual scroll thickness -250 and 140 residual is very high, very risky. More than 300 is good. Thick corneal thickness below 450 is very high risk of ectasia. More than 510 is more or less, and it means we are original more than 14 high and risk. And generally speaking, in case who had been found to having ectasia, has been found that the most important factor is common in these cases is the topography, abnormal topography pattern, which should be considered sharp. If you have a score 0 from 2 score, we can do. We can 0 to 2, we can have low risk, so we can proceed to a laser self-ablation. 4 or more don't perform LASIK, and 3 proceed with caution. Studying effective self-treatment lines like cross-linking, keratoconus changes, pachymetry, grading. This is a case of keratoconus with inferior steepening, asymmetric bowtie, having anterior floor plus 14, posterior floor plus 14, and thickness 478. What happens after 3 months of cross-linking? The shape is more better. The shape has becoming more normal. Upper becomes bigger and lower decreases, and the axis is forward. The floats decrease from to +10, and the inferior +8, and the thickness decreases by about 30 microns because of the backing of the corneal limit. Pre-cross linking, also the curves were abnormal. What happened after 3 months? The curves getting a more regular shape, and the coma aberration decreased dramatically after 3 months. Other machines like Sirius and Galileo This is Ben Ambrosio. Just rapid بس remind ان احنا what's Ben Ambrosio and we remove the central 3 mm thin location and 3 mm above and make a new reference surface and it's flatter than before. This way the keratoconus cases are seen more يعني with accuracy and normal cases become still normal. If the yellow spot is كده is suspicious, if a red is abnormal. This is its advantage ABC system and this is to مثلا. Thank you.